Dear colleagues, welcome to today's EACVI webinar on highlights of EuroCMR 2019. I'm Professor Steffen Petersen from Bart's Heart Center and Queen Mary University of London, and I have the pleasure of being joined by Dr. José Rodríguez Palomares from University Hospital Vall d'Hebron from Barcelona. The aim of this webinar is to give you a personal perspective of a selection of the highlights from EuroCMR 2019. This session is interactive, and we strongly encourage you to actively participate by sending your questions or let us know what your personal highlights of EuroCMR 2019 were, or any other comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of 3 multiple-choice questions that will be submitted during the presentations. So I wanted to take you through, this is my disclosure slide, I wanted to take you through the topic of the conference, which was entitled Quality Through Evidence and CMR Innovation. We wanted to celebrate the success and evidence of CMR and the quality it can provide in healthcare. We wanted to acknowledge and identify gaps of our knowledge and evidence and discuss how we can address these gaps in knowledge. By doing this, we would consider how we can demonstrate the value of CMR in the context of very limited healthcare resources and consider how we can tackle the challenges, the provision of appropriate use of cardiac MRI to those who need it. And I think that this conference has succeeded in providing a platform to discuss this in a lot of detail. Just to give an overview, it was a successful conference in my view. 2.5 days of scientific sessions with record numbers of delegates, almost 1,400 from 71 countries. And we had record number of abstracts submitted of extremely high quality. Some of you may have set the CMR exam. So we had over 200 people sitting the exams, and they will hear in due course about the exam results. The program has to be organized by many people that have to be thanked, and you can see many people who have contributed substantially to the organization of the program who I'd like to thank here particularly again. But importantly, I wanted to thank Veronique, Audrey and Oceane for supporting us throughout the year to make this a really successful conference. It was absolutely wonderful working with you. And the entire EuroCMR 2019 staff team from the ESC has also done an absolutely superb job. A conference of this size and scale cannot be organized without industry partners to support our conferences. And I'm listing here all the companies that I would like to express my thanks for supporting us again. But Jose, who you will hear give the highlights in a minute, has really done a tremendous job as the scientific program chair, and I'd like to thank him particularly. But he was supported by a team that you see here, including Anna Almeida as the abstract chair, local hosts Chiara Bucciarelli-Ducci and Martina Perazzolo-Mara, and supported also by Bernard Gerber as the Vice President-elect of CMR. Without further ado, I will now hand over to Dr. José Rodríguez Palomares for the presentation.
Thanks so much, Stefan, for the introduction. First of all, I would like to thank the audience for the participation in this webinar. In the next slides, I will try to highlight some of the topics that were discussed in the last EuroCMR, but you have to understand that it is impossible to explain all the topics that were addressed in the meeting, but at least I will try to summarize the most relevant information. So this is a summary of the present. I have no disclosures in this presentation. So this is the summary or an overview of the next slides that I will introduce. So we will start with CMR, the role of CMR in cardio-oncology. So as you know, in cardio-oncology, we need biomarkers are needed at different endpoints like risk stratification, early detection of cardiotoxicity, prediction of recovery, and screening of survivors. And the requirements of biomarkers are that they should be standardized, they have to present high reproducibility, they have to be available, they have to be cost-effective, and they should be an early marker of the disease. So, but what is the definition, or what is the definition of cardiotoxicity? So based on the consensus of the American Society of Echocardiography and the European Association of Cardiovascular Imaging, so cardiotoxicity is defined as a decrease of the left ventricular ejection fraction higher than 10%, as we can see here, and also a relative reduction of the global longitudinal strain higher than 15%. But we know that left ventricular ejection fraction by 2D echo is a suboptimal biomarker for cardiotoxicity screening. And we also know, as we can see in this graph here, that even in good quality scans, only one imaging technique can detect differences lower than 10%, and this imaging technique is CMR compared to the rest of the imaging techniques. We also know that Leggadolinium enhancement cannot be a good predictor of cardiotoxicity because it's unusual in patients, in cardio-oncology patients. And also T1 mapping is not the answer because we had different results in different studies. As we can see here, in this study here, it was proposed that native T1 increased after the initiation of the treatment. However, in this study here, it was shown that native T1 decreased after the initiation of the treatment. So as I stated here, T1 mapping cannot be considered the answer. But however, a new predictor for cardiotoxicity was discussed in this recent study. In this study performed in pigs, 4 different groups were established, as you can see here. So in the first one, 5 doses of doxorubicin were given to the animals, and they were followed for a period of 16 weeks. In the second group, 3 doses of doxorubicin were given to the pigs, and they were followed also for 16 weeks. The third group, only 3 doses of doxorubicin were given, and they were not followed, and the fourth group was the control group. So as we can see here in the first group, what they found was that there was, after the doxorubicin, the 5 cycles of doxorubicin, there was a decrease in the ejection fraction, an increase in the native T2, and also an increase in the extracellular volume. What they stated here in this study was that a low cumulative dose of anthracycline implies no toxicity. There was no changes in T1, T2 mapping. There was no changes in left ventricular motion, and there was no changes in histology. However, when we had higher cumulative doses of anthracycline, so the doxorubicin was continued, so we arrived to an irreversible stage. The T2 mapping was affected, the T1 and the extracellular volume was increased, and there was a massive alcoholization and fibrosis in the cardiomyocytes. So they stated that T2 can be a good biomarker for cardiotoxicity in cardio-oncology patients. But cardiotoxicity is not only related to anthracyclines, but also associated with immune checkpoint inhibitors, which can induce myocarditis. As we can see here, cases of fulminant cardiomyocarditis have been seen and have been described in different studies. So now we are going to raise the first question about this section in cardio-oncology. So what we are asking you is, regarding the use of cardiac imaging in cardio-oncology, which of the following statements is correct? So 2D transthoracic echocardiography is the most reproducible method to determine changes in left ventricular ejection fraction. Changes in myocardial native T1 constitute the earliest predictor of cardiac toxicity. Cardiac involvement has been only described with chemotherapy, but not with immune checkpoint inhibitors. And 4, the presence of a persistently elevated T2 signal could be associated with irreversible cardiotoxicity.
So you've got about 20 seconds, I think, left now to do your vote. I guess, Jose, I thought that we had a wonderful overview lecture by Charlotte Manistee in the opening plenary, which I think was just wonderfully setting the scene then for this dedicated session that we had on cardio-oncology. Would you agree?
Yeah. In fact, she gave like 2 presentations in this cardio-oncology topic. The sessions were fully attended. I think it's a very important topic that everyone is very interested in cardiotoxicity, because we have lots of survivors or patients that survived a cancer. And I think just trying to find a good predictor for cardiotoxicity, I think it's a high interest for our cardiology community. And I think some of the questions were raised by Charlotte Manisty in the meeting. Yeah.
So thanks. The results have come in, so our listeners have voted. And do you want to go to the correct answer? So most of them thought that option 4 was the correct answer.
Exactly.
Which is correct. So well done to those who got it right. But a substantial number of people also thought that option 1 or 2 might be the correct ones. Do you want to just comment on that a little bit, Jose?
Yeah, the thing is that, as I raised or I explained in the previews, is that 2D echo is a good imaging technique just to analyze cardiotoxicity. But the problem is that when we detect a decrease in the ejection fraction, that means that the cardiotoxicity has been already established. And we want to be, we need a predictor, so a marker that can predict cardiotoxicity before the cardiotoxicity appears. So that's why 2D echo at this time, first of all, because the reproducibility is lower, and also because when there is a decrease in the ejection fraction, that means that the cardiotoxicity is established. And the second option, what I showed is that it could be a good predictor, but the thing is that we have like different results in different studies, and we don't know exactly the behavior of the T1 in cardio-oncology patients. So that's why at this time point, the main paper established that T2 can be or could be a potential marker of cardiotoxicity.
Great. Thank you. But I think this field will still evolve significantly over the next few years, and there's plenty more to come. So just an encouragement again to those who listen, you can send your questions through. I will collate them and either in between the sections ask the questions to Jose, or otherwise I'll collect them once we've gone through all the sections, and we'll ask the questions then. But we're making good progress. So Jose, over to you to start the next section.
So the next section will be about CMR in cardiomyopathies. So although it is not included in the ESC guidelines and in the ESC hypertrophic cardiomyopathy risk calculator of sudden cardiac death, there is an increasing evidence that the presence of late gadolinium enhancement increases the rate of cardiac sudden death. And this rate can be 3 to 6% higher compared to patients without late gadolinium enhancement. As we can see here in a recent meta-analysis with positive results and with overlapping results, the odds ratio of late gadolinium enhancement to predict cardiac sudden death was 2.9. However, in this other part here, when the studies with overlap results were excluded, the odds ratio could be as higher as 3.4. So that means that late gadolinium enhancement could potentially help us in order to know what are the patients with higher risk of sudden cardiac death if they present a hypertrophic cardiomyopathy. But similar results were found in patients with dilated cardiomyopathy. And as we can see here, this study with patients with dilated cardiomyopathy with an ejection fraction lower than 35%, all of them fulfilling criteria for an ICD, but the ICD implantation finally was implanted based on the clinical decision. So was decided by the doctor in charge of these patients. And they analyzed the primary outcome that was all-cause mortality. And what they found here is that in patients with a dilated cardiomyopathy and the ones who presented late gadolinium enhancement, so the mortality was decreased if the patients presented or were implanted an ICD. However, in the ones with no gadolinium enhancement were not differences in between the ones with an ICD or without an ICD. So late gadolinium enhancement again increases the risk for sudden cardiac death in patients with dilated cardiomyopathy. And what about the risk stratification in patients with arrhythmogenic cardiomyopathy? So in this study here, also discussed at EuroCMR, 528 patients from 14 centers, 6 countries were included, and patients had to fulfill the diagnostic criteria of EACVI based on the 2010 criteria, and they had not previous ventricular tachycardia. So the main risk factors associated with poor outcome in patients with ARVC were male sex, age, the presence of a recent syncope, non-sustained ventricular tachycardia, the number of PVC in the 24-hour Holter, the number of leads with T-wave inversion, and the ejection fraction of the right ventricle. So finally, they considered all these risk factors, and they came up with also a calculator similar to the one that we are using for the hypertrophic cardiomyopathy. And the higher the risk the patient has, as we can see in the previous slide, the higher the risk the patient, so the higher the poorest prognostic that the patient can have in cases with an ARVC. You can check the calculator at this web page, so you can use it for your patients. Also, in patients with non-compaction cardiomyopathy, the presence of Leggadolinium enhancement was associated with a higher rate of cardiovascular events, as we can see here. So thus, in patients with a preserved ejection fraction and no Leggadolinium enhancement, most of them did not present cardiovascular events, and only a minority of patients presented cardiovascular events, as we can see here. However, in the other end of the spectrum, we had the patients with a decrease of left ventricular ejection fraction and presence of the Leggadolinium enhancement, which present a higher rate of cardiovascular events and heart cardiovascular events, as we can see here. Let's move to the athletes. So there was also a session for athletes and cardiomyopathies in athletes. And as you can see here, Leggadolinium enhancement can be present in at least 10% of the athletes based on different series. Different hypotheses have been proposed, like myocarditis, silent myocarditis, or an inherited cardiomyopathy, the use of drugs like anabolic or androgenic steroids, or also the effect of the strenuous exercise could explain this presence of Leggadolinium enhancement here. And what it was suggested at the meeting was that if the presence of this Leggadolinium enhancement is silenced, so we should look for the patient, study the patient, so perform loop recorder test, also ergometric test, just to make sure that there are no arrhythmias. In case that the Leggadolinium enhancement presents a familiar role, so we have to say that there are no data on gen mutations and sports and in athletes. In the ones that the Leggadolinium enhancement is not familiar, we have to think about alternative diseases like sarcoidosis, as you can see here. In cases of Leggadolinium enhancement and the presence of malignant ventricular arrhythmias, an ICD implantation should be considered. And in cases with no evidence of malignant ventricular, it is under discussion if they should prudentially refrain from practicing sports. That's under debate, and there is not a clear solution for those athletes. Also, it was right ventricular enlargement can be physiologic in athletes. However, sometimes it is difficult to differentiate right ventricular remodeling from ARVC, since the presence of anterior T-wave inversion and ventricular ectopy can be seen in both entities. So it was discussed this session, and here there is a chart where we can see that the main criteria that suggest or they are more suggestive of ARVC, and this ratio in between the right ventricular diameter and the left ventricular diastolic diameter by echo, the right ventricular fractional area change lower than 30%, that the right ventricular and diastolic volume divided at the left ventricular and diastolic volume higher than 1.2, right ventricular ejection fraction lower than 40%, right ventricular wall motion abnormalities, and the presence of myocardial fibrosis and fat infiltration are more suggestive of the presence of an ARVC. So now we have a new questions for the audience. So regarding the use of CMR in cardiomyopathies, which is the following is incorrect? So Leggadolinium enhancement can be present in up to 10% of athletes based on different series. That the presence of wall motion abnormalities in the right ventricle are commonly described in healthy endurance athletes. Leggadolinium enhancement is associated with an increased rate of cardiovascular events in patients with dilated cardiomyopathy. And although it has prognostic implications, the presence of Leggadolinium enhancement is not included in the ESC calculator to assess the risk for sudden death in patients with hypertrophic cardiomyopathy.
So people have 10 seconds left to vote. So let's see what the results are before we show what the correct answer is. So I've got the results now. I can see that 67% thought option 2 is correct. 22% thought that option 3 is correct. Or the numbers are still changing, so people can still vote. So it's now 75% think option 2 is correct. 17% option 3, and some thought option 4 is correct. But the most commonly used ones are option 2 and 3. So do you want to just talk about those a little bit, Jose, 2 and 3?
It is clear that the presence of wall motion abnormalities in the right ventricle are commonly described in healthy endurance athletes. So that is associated with pathology, as I described in the previous chart. So this is a very specific. Athletes can present an increase in the volumes in the right ventricle, but the presence of wall motion abnormalities, they should be considered, and maybe we have to consider that this is not physiologic, that can be part of the pathology. And also, the presence of Leggadolinium enhancement is associated with an increased rate of cardiovascular events in patients with dilated cardiomyopathy. This is correct. So as we described in the previous slides, so in cardiomyopathies, the presence of Leggadolinium enhancement implies a poorer prognosis in those patients.
Okay, so thank you. So I'm getting a few questions in, but I think we're sort of making quite good progress and we don't have too many questions yet. We'll keep them for the end and just move on.
So now we are going to move to the next section, that is CMR in valvular heart diseases. So the first in TAVI patients. So what we can consider is that CMR can be an alternative of CT in TAVI patients, because we can evaluate aortic annulus area, the distance to the right and the left coronary arteries. And as we can see here, the correlation in between CT and CMR is very high, so it could be an alternative to CT. Also, we can evaluate periprosthetic leaks. We have to make sure that we are measuring the flow just below the prosthesis or just above the stent. We want to avoid the artifacts, so we want to have a better measure. That we can assess the presence of cerebral embolization in patients after TAVI, and this embolization is related to the severity of the aortic valve calcification. And also we can evaluate the abdominal aorta and the iliofemoral arteries in those patients, because CMR is also good for arteries and vascular peripheral arteries. So we can say that CMR can be an alternative to CT in this population. Also in patients with mitral valve regurgitation, we can say that echo for sure is the first line imaging technique to assess the mechanism and the severity of the mitral regurgitation. So there is no doubt about that. That maybe CMR can improve the prognostic value if we want to evaluate the severity of mitral regurgitation. There are some papers talking about the prognosis implication of the severity of mitral regurgitation assessed by CMR. But CMR can also predict the risk of malignant arrhythmias in patients with mitral regurgitation. We know that Leggadolinium enhancement can be present in up to 37% of patients with mitral valve prolapse. And the presence of Leggadolinium enhancement also implies a poorer prognosis in patients with mitral regurgitation. And also the severity of myocardial fibrosis is associated with the severity of mitral regurgitation. So as we can see here in this graph, so the higher the severity of the mitral regurgitation, so the higher probability that the higher probability of presenting fibrosis replacement in those patients. even in patients with mitral valve prolapse, as we can see here, and in patients with non-mitral valve prolapse. So it can be a predictor of fibrosis. So moving to other uses of CMR, we have to do an introduction of the role of PET-MR. And PET-MR can be an excellent imaging technique to evaluate patients with atherosclerosis. So in this study here, discussed at EuroCMR, the authors use FDG PET-MR to study 755 patients of participants of the PISA study. So as it was displayed in this study here, the presence of plaques was associated with the number of cardiovascular risk factors, as you can see here. So the higher the risk factors, so the high probability of atherosclerotic plaques. Also, plaques were present in 90% of the participants. So that was an overwhelming result, so a very remarkable result. The presence of arterial inflammation was present in 48% of the participants, and the inflammation was also associated with the presence of cardiovascular risk factors. As you can see here, the more cardiovascular risk factor, the more uptake in fluorodesoxyglucose here. And also inflammation was present in 11% of plaques, and most uptake was seen in plaque-free segments. And they also consider here that the most prevalent atherosclerotic plaque were found here in the brachiocephalic trunk and in the iliofemoral arteries, and also in the lower extremity arteries. And the more inflammatory plaques were seen in the brachiocephalic trunks, and also in the descending thoracic aorta, and also in the peripheral arteries, in the lower extremity peripheral arteries. So now let's move to the next section, that is recent advances in CMR. So this is very important because what I'm going to discuss here are the different trials and the different studies that research studies that were presented in the EuroCMR. So we are going to start with this interesting study. So this first study, which was one of the winners of the Young Investigator Hour session, discussed the use of deep learning to define 6 left ventricular phenotypes. So left ventricular end diastolic volume, left ventricular and systolic volume, the stroke volume, the ejection fraction, the mass, and the mass to volume ratio. And what they found, they showed that deep learning can decrease the post-processing time. So as we can see here, we can study, or we can post-process 5,000 studies in 7 months. However, we can, using deep learning, we can analyze 15,000 studies in less than 1 week. So it implies that we can decrease the post-processing time. And also 28 genes were identified, have been identified to predict the 6 left ventricular phenotypes, as I presented before. The 6 phenotypes are left ventricular volume, such as an ejection fraction. And also, this study finally assessed a risk score model that was generated to predict left ventricular and systolic volume. And this model was also used to predict the risk factor for left ventricular heart failure. So I think this is very important, just because it emphasized the role of deep learning and also the genes that are associated with these different cardiovascular or cardiac phenotypes. So in this second study, the authors evaluated the feasibility and prognostic value of vasodilator stress perfusion in obese patients with a body mass index higher than 40 kilograms per meter square without known coronary artery disease. So in this study, 404 obese patients were included, and the piridiamol stress test was performed at 1.5 Tesla. And in this study here, the presence of inducible ischemia and the presence of Leggadolinium enhancement was associated with MACE and cardiovascular mortality at follow-up. As we can see here, the hazard ratio of the presence of inducible ischemia and Leggadolinium enhancement was associated with MACE and cardiovascular mortality. So also this study here, exercise CMR was used to differentiate patients with dilated cardiomyopathy from healthy individuals with an increase of left ventricular in diastolic volume and a decrease in left ventricular ejection fraction. We know that some athletes can present increase in volumes and a small decrease in the ejection fraction, and we want to differentiate what's physiological from pathological. So in this study here, patients with a dilated cardiomyopathy did not present a high increase in the cardiac index, as we can see here, so lower than the cutoff value of 35 percentile. So, and in this study here, an increase lower of the 35% percentile was more present in dilated cardiomyopathy patients with a sensitivity of 100% and a specificity of 66% to diagnose dilated cardiomyopathy. Also, the combination of clinical risk factors such as age, sex, left ventricular dilation, decreasing the ejection fraction, and again, the use of the peak exercise cardiac index can increase the diagnosis value of CMR in patients with dilated cardiomyopathy. And also, as we can see here, patients with a cardiac index lower than 35 percentile presented a higher risk of events at follow-up. Also, this study here, after a heart transplant, Leggadolinium enhancement can be present in almost 18% of patients. So the more severe is the cardiac allograft vasculopathy, the more severe is the presence of Leggadolinium enhancement. Different patterns, such as ischemic and non-ischemic, has been described. And also in this study here, the presence of fibrosis in this population is associated to a higher rate of MACE at follow-up. So the higher the fibrosis, so the lower prognosis, the higher rate of MACE can be described in this population. And also the presence of fibrosis is associated with the cardiac allograft vasculopathy. So the more severe the vasculopathy is, the more probability to present fibrosis in this population. Also, this interesting study randomized patients to receive Alteplase after revascularization, so in acute myocardial infarction, and they the aim of the study was to show if there was a decrease in the microvascular obstruction in those patients, and they saw that with the use of Alteplase, the microvascular obstruction was not decreased. So even though there was an increase in the microvascular obstruction, so possible mechanisms were the hemorrhagic transformation of patients, prolonged ischemia leads to capillary degradation, and in these circumstances, Alteplase may promote hemorrhage. However, when we check the presence of cardiovascular events in the different subgroups, there were no differences of outcomes in this population, so at follow-up. So it seems that the use of Alteplase, intracoronary Alteplase, doesn't decrease the microvascular obstruction and does not imply a better, so a good prognosis in patients with an acute acute infarction. And finally, also this interesting study was also performed in order to know if it was safe to use non-MRI conditional leads. 50% of non-MRI conditional leads were used. So they report that no change in leads in the lead thresholds was observed, and also in this study there were no events in those patients, even with the use of non-MRI conditional leads. So that means that the use CMR can be used in patients with pacemaker and defibrillators, and even in those patients with non-MRI conditional leads. So after this section, I'm going to raise the third question. So regarding the use of CMR, which of the following is incorrect? So the use of artificial intelligence can significantly reduce the post-processing time. A reduced peak exercise cardiac index could potentially differentiate patients with dilated cardiomyopathy from healthy individuals. CMR seems to be safe in patients with non-MRI conditional leads, and the use of intracoronary Alteplase can reduce the presence of hemorrhagic myocardial infarction and reduce the rate of cardiovascular events at follow-up.
Excellent. Thank you, Jose. So there's about 5 seconds left for voting. So hopefully people have put in their guesses or their knowledge. So we've got the first results in. So before you show, so we have the front runner of the, I guess the answer that is incorrect is number 4 with almost 80%. And question number 3 or answer number 3 has 20%, 21% of people voting for it. So maybe you want to just comment on the last 2?
Yeah, so as I showed in this study that I recently presented, so the authors showed that the hypothesis was that using intracoronary arteplase could reduce the presence of microvascular obstruction, but they didn't see these results. So the amount of microvascular obstruction did not decrease with the use of alteplase in those patients. And also, as I showed, the presence of cardiovascular events in the different groups was similar. So there is no benefit in terms of outcomes in this population. And here, this was a very interesting study that opened the use of CMR in patients with pacemaker and defibrillators. And this is a study performed at Barts, and it was presented by Charlotte Manesty. And it was very interesting because she showed that 57% of patients with pacemaker and defibrillators that presented non-MRI conditional leads, so they present no events during the scan. So that, as I mentioned, that opens the use of CMR in patients with defibrillators and pacemakers. So that's why this is correct. So that can be safe in patients with non-MRI conditional leads.
Wonderful, thank you. So shall we move on?
Yeah, so in the next section, I'm going to talk about new sequences that were discussed at EuroCMR. So the first one will be 4D flow. So there were lots of sessions about 4D flow. So we know that 4D flow is being used for heart valve disease, for aortic dissection, and for the study of aortopathy in patients, mostly in patients with bicuspid aortic valve. So we know that the use of 4D flow implies like 8 to 10 minutes in those patients, and the future directions are coming to highly accelerated imaging in order to decrease the scanning time. So 5D flow imaging, I will let you know what's that about, and also artificial intelligence and deep learning. So what about highly accelerated imaging? So there has been they were presented works, studies about the use of compressed sensing in 4D flow imaging, and as we can see here, we can get, with compressed sensing imaging, we can get an acceleration rate of 7.7 versus the conventional 2. We can get the same spatial and temporal resolution, and the acquisition time can be decreased to 2 minutes with the same quality of imaging and the same results in terms of flow. So that could be a good solution for the flow. Also, we are moving to 5D flow. That means the combination of flow, 4D flow, so flow, time, and also the anatomy, so the 3D anatomy of the patient, so the anatomy, the anatomical information, the left ventricular volume and ejection fraction. So that could be challenging and could be very interesting. And finally, the use of deep learning in artificial intelligence in 4D flow. We know that most of the most tedious work in 4D flow is segmentation, and as you can see here, so this is a segmentation based on artificial intelligence and a manual segmentation, and we can see that there are only subtle differences in between both of them. And as we can see here, the diameters at different levels are very similar. So in between these two red, manual and automatic, are the aortic arch and descending aorta. So the diameters were very similar. So this is promising because this was one of the most challenging parts for the flow, so segmentation. So good information about that. And that the last part of the new sequences. So Dr. Ferrari talked about fingerprinting. So the uses of fingerprinting is that it could be used for native post-contrast T1 maps, so the calculation of extracellular volume, T2 maps to determine the presence of edema, and non-contrast change in T1 parameters post-vasodilator for stress testing. So the advantages of MR fingerprinting is that does not rely on complete recovery decay between imaging periods, so more accurate and reproducible T1 and T2 values with shorter scan times, more immune to hair rate bias, so it could be also used in patients with arrhythmia, and may be used to characterize tissue properties beyond T1 and T2 maps, so perfusion, diffusion, fat fraction, and extracellular volume without the use of contrast. The conclusion of Dr. Ferrari about this sequence is that they are not still available for a clinical use, but I think they can be, and he suggested that they can be promising in the future.
So wonderful, Jose. That's a great summary. So we have one last section that I wanted to talk about before we go to questions and start wrapping up. A really important session for me personally was the session called Value of CMR in Healthcare, because it was related to the entire topic of the conference. And that was organized jointly between the European Heart Academy, the EACVI, and the London School of Economics. You may know that for a few years now, the ESC, through the European Heart Academy, have been sponsoring and supporting an executive master's at the London School of Economics for health economics, outcomes, and cardiovascular management. And I was lucky to be one of the people who've done this course and finished it last year. So we thought it's good to bring some of the faculty together to basically discuss how CardioMR can be viewed in this topic. And we were lucky to have two professors from the London School of Economics, Miktat Azaria and Rocco Friebel. Miktat Azaria basically gave an excellent talk on the cost effectiveness of CardioMR, providing some overview what we actually mean by that, how it's done at a very high level, because it's really quite complex to do. And he left with some important questions, which I think I wanted to show you here, because cost effectiveness analysis is not something that you can do on the back of an envelope. It really requires a lot of thinking, a lot of assumptions, a lot of data searching, a lot of data acquisition to demonstrate against other modalities or other alternatives. So whether something is cost effective. So what are we comparing to? Is it part of which treatment pathway? Populations may differ, and in which health system. So something may be cost effective in England, but it may not be cost effective in your country, Jose, in Spain. So it's just something to bear in mind that is very, very context specific. And also the context is obviously, the time of assessment. So over time, this may change, data may change, and costs for CardioMR scans might come down, or echo scans might become cheaper, echo might become better. So when you talk about cost effectiveness and you do an analysis, it really is very context specific. So I think that was a really important learning point for me. Then Rocco Friebel gave an excellent talk on the research designs to demonstrate value of CMR. And he started off by saying, well, the gold standard is really the randomized controlled trial. But he then showed that there's other much less familiar ones to us in this field, that there's research studies, research designs that basically help assess the value. It's a bit too much to go into detail here, but all of this is part of demonstrating the value and constantly improving your healthcare services. And this is a quite famous drawing from Friedman in 2014, showing the learning healthcare system, how you basically through a feedback loop change, gathering data again, analysis of your data, interpretation. You can kind of have this feedback loop and constantly improve the healthcare that you provide. I gave a bit of an overview before we had a fantastic panel discussion with some other key experts on why are we actually doing CardioMR, because we're part of an overarching healthcare system. So I reminded people of the triple aim of health systems, which is essentially around the quality of healthcare, access of healthcare, and containing the rise of costs of healthcare. So we want to achieve, maintain, and improve the quality, and we want to ensure, maintain, and improve the access of healthcare. And you can see that this is basically a cycle. So it's not a static thing. We constantly want to improve. And I just gave some examples that were sort of a stimulus for the panel discussion later as what can we as a CardioMR community do, essentially to maybe improve the quality of healthcare. And I've listed a few here, like develop standards through consensus papers, gather more evidence and communicate them in publications, in journals, in conferences like EuroCMR, be involved in developing guidelines, try and understand why there is quite a lot of non-compliance with guidelines. We can certify, accredit labs and recertify to raise standards. So these were just some of the thoughts. How about access to quality of CMR services? In some countries, it's really difficult to do because they don't have enough trained staff. So I guess that's partly what we're trying to do, having centers of excellence and accredited labs, that we have a mechanism of training enough people. We want to make sure, for example, that we can help people with business cases to make a case to their hospitals that they should buy cardiac MR scanners. As a community, we obviously want to shorten the cardiac MR exams, make them more straightforward to acquire, including the analysis. And I think artificial intelligence will play a key role here. So I think this brings us really to the end of the highlights that we've put together. So thank you, Jose, really for making this tremendous amount of work and looking through all of the slides again and really picking some of the, for you, important highlights. So I think we now have about 8 to 10 minutes or so to go through some of the questions, and then we'll wrap up. Is that okay, Jose?
Yeah, perfect.
So I'm just gonna go through the list of questions I have here. So somebody asks, what is fingerprinting? So maybe if I kickstart this, so this concept I've heard about for the first time, I think about 2 years ago, and sort of called MR fingerprinting. And I think it originally came from brain imaging, actually. And I got very confused what this is supposed to achieve, because for me, fingerprinting is when I think about, when I give my fingerprint, it's because somebody wants to compare to a catalog in a database to work out whether I'm really the person who I say I am. So if I go into the US, let's say, and I put my fingerprints on it, they check that it's really me. And I think that term to me was misleading and really confused me, because what this certainly isn't aiming to do, this technique, is to scan the heart and then say, well, this is Stefan's heart or Jose's heart. So it's not about identifying the person's heart, but this is about tissue characterizing, so tissue fingerprinting. So it looks up essentially tissue characteristics in the catalog and then tells you, the T1 value might be X, Y, and Z, or the T2 value might be X, Y, and Z. That's my understanding. And this is one of a number of techniques that basically sort of in a one-stop shop give you a lot of tissue characterization. Do you think that's a fair explanation?
I think you did a very good explanation about what this topic is. So it's going through the tail of the tissue characterization without the use of contrast. I think that's the main important value of this sequence, that without the use of value, we can analyze the different characteristics of the tissue. We can calculate, or it is supposed that we will be able to characterize the extracellular volume, for example, without the use of contrast. So because we can have the T1 native and the T2 based on the tissue characterization. So I think you did a good definition of that.
So then let me ask you another question. This was related to your second section about cardiomyopathies and ARVC. So this is about diagnosing ARVC. So somebody asks, does it make sense to look for fatty infiltration of RV to diagnose ARVC?
So the thing is that there was a very interesting session about if we are in time just to redefine the definition of arrhythmogenic cardiomyopathy. So Dr. Corrado explained about that, and of course that we are moving from the triangle of the arrhythmogenic arrhythmogenic cardiomyopathy, we are moving to a four quadrilateral of the cardiomyopathy, so arrhythmogenic cardiomyopathy. The problem is that fat infiltration in the right ventricle is very difficult to assess. That's why in the first definition of arrhythmogenic cardiomyopathy, it was of the criteria, but it was eliminated this criteria in the 2010 criteria because it's very difficult. In our center, what we are doing is we also do T1 weighted images in those patients, because if we found the presence of infiltration in the left ventricle, so it can suggest, or it can help us in order to be sure that it's an arrhythmogenic cardiomyopathy. So for the right ventricle is difficult, but we can use T1 weighted images for the left ventricle.
Excellent. Thank you, Jose. So there was another question that I thought was very interesting, and I'm not sure that I can give a definitive answer to this, so I'd be interested to hear your thoughts, Jose. So do you think the main mechanism of myocardial injury and cardiotoxicity is due to chemotherapy is inflammation? So is inflammation the common mechanism?
So it was one hypothesis, but what it has been suggested in this EuroCMR is the presence of intracellular edema, more than the presence of extracellular edema. So this paper that I showed you that was performed in different peaks, that different doses of doxorubicin was given to these animals. So they showed that the main anatomopathological issue that was observed was the presence of intramyocyte vacuolization and intramyocyte edema. That was the main mechanism of the increases in the T2, more than the presence of other inflammatory mechanisms or extracellular edema. So that had been raised, but I understand that the hypothesis of inflammation has been considered as an alternative hypothesis for the increase in the T2, in the native T2 images.
Wonderful, thank you. So then I have one more question, and again, I have to say maybe you know the answer because I couldn't go to the pericarditis session. There's a question about pericarditis. Were there any novel data presented regarding the use of CMR in patients with pericarditis? And I'm not going to hold you to it because I know you've also been busy during the conference, so you may not know exactly what's being presented in this session.
I didn't go to the session, but I went to the I just reviewed the presentation, the different session, the different talks that were in that session. There were no new concepts about pericardial diseases. The only thing that it was still that the presence of Leggadolinium enhancements in the pericardium can be a prognosis factor also in patients with pericardial diseases. So Leggad also in the pericardium also associated with prognosis, and just consider that the presence of inflammation and Leggadolinium enhancement just to be considered in those patients, just to emphasize the anti-inflammatory treatment and give the patients an opportunity before doing surgery, because that means that if there is gadolinium enhancement in the pericardium, that can be associated with inflammation, and in an acute stage, that can be the patient can be prone or can be benefit from the use of anti-inflammatory. There were no other big data in pericardial diseases.
Okay. Thank you. So I think we may have time for one more question, so see how that goes. So this is a question that I'd be interested to hear your thoughts, Jose. Is there a state-of-art use for the T1 and T2 mapping at present? So
there are lots of, I mean, you mean the state-of-the-art about the sequence or about the clinical use?
I think the question is probably, or at least that's how I understood, is probably asking about the sequences. Is there now an agreement in terms of which sequence to use, etc.?
Well, the thing is that the consensus is it's very, what is very standardized, that different sequences has been established. So different vendors have their own sequences. What it is established that every center should perform at least 30 controls just to make sure about the normal values. I think that there is no doubt about that, because that will be the normal values in your center, and that will be the control group for in order to be sure that they are a pathology group with an increase or a decrease in the normal value. Just for example, in our center we are using the SMOLI one, for example, but we have to consider that different vendors, different sequences with different values for 1.5 Tesla, different values for 3 Tesla. That's why we have to have our 30 control group. I think that's the most standard thing. And I don't know if you want to add any information on this issue.
No, I think you've covered it very well. Also, we are running out a little bit of time, so even though we still have a couple or 3 questions left, I think I'm going to wrap up, just reminding you that if you want to revisit EuroCMR 2019, there's a number of ways that you can do that. You can go to the actual presentation. So we've given you an overview, but if you want to look at the actual presentations, you can do that through ESC 365. And also, a number of highlights were actually recorded on EACVI, so you can find that if you Google that. The abstracts will be online. We had industry satellite symposia, and they have screencasts, so you can look at those if you miss those. And obviously, you can go back to this seminar, on-demand webinar, and look at it again. Also, what you might want to do is look at hashtag EuroCMR and see what's been posted on Twitter, because there was quite a lot of activity going on during the conference and shortly after the conference. I wanted to stop and make a few announcements. So next year, we do not have a EuroCMR 2020 conference, and I'll say in a minute why that is. But we have something really interesting in London, which is an Artificial Intelligence and Cardiac MR conference, which is a joint summit of the EACVI and SCMR. And the dates are 28th to the 29th of May 2020. So you want to put it in your diaries already if this is of interest to you, but there'll be more announcements in due course. Next year, there will be some changes. So there's no EuroCMR next year, but we have a new conference called EACVI 2020 from the 9th to the 12th of December in Barcelona, which will be a true multimodality conference. And our next EuroCMR conference is in 2021 from the 6th to the 8th of May in Seville in Spain. So in your country, Jose.
Hey, perfect.
So two big conferences in Spain. But also, if you're interested in EuroEcho 2019, that's taking place 4th to the 7th of December in Vienna. And with that, I'd like to leave you with a few pictures from people who I think really enjoyed the conference. I certainly did. And Jose, thank you again for putting the highlights together for today, but for your tremendous amount of work and excellent work you've done to put EuroCMR 2019 together.
Thank you very much, Stefan, and thank you very much to everyone who attended the EuroCMR. We all enjoyed the meeting very much.
So with that, goodbye from both of us. Bye-bye.
Bye-bye.